Top Med Talk. We're here at the 3rd Annual Transatlantic Quality Improvement Leadership Forum, focusing on perioperative medicine and enhanced surgical recovery. I'm Monty, Editor-in-Chief of Top Med Talk, the broadcasting arm of evidence-based perioperative medicine, that's EBPOM, and I'm joined today by special guests, Dr. Peden from USC, so University of Southern California, Dr. Andrea Kurz from the Cleveland Clinic, and Dr. Fleisher from UPenn, who's co-chair of this meeting, and also relatively recently appointed as the editor-in-chief of the journal Perioperative Medicine. Now, this forum is a gathering of leaders in perioperative medicine and enhanced recovery to share ideas and hopefully drive dissemination of best practices. So just very briefly touching on the opioid crisis, for example. Lee, what did you hear yesterday?
Well, what I heard yesterday and what we're doing in our own system is we're partially at fault in that we've given our patients too many opiates to take home. They continue them for 6 months or a year if we give them enough, and that what many health systems are doing is certainly restricting post-discharge opiates. And then what I heard from numerous individuals is whether or not there's an advantage to reduce opiates perioperatively, in the hospital.
So we heard about some people trying to do opioid-free anesthesia stroke analgesia. We heard about some people trying to send patients home with no opioids. And we heard that some people are down now to 3 days to that. But other people are still way out there. Carol?
Yeah, I think, again, any moves we can to be sensible about our opioid use. Obviously, we want our patients to be comfortable, but the comment we were discussing last night is that if you're still taking opioids several weeks after your operation, surely the clinicians want to know, because why is that patient still in pain? If it's a joint replacement, something's clearly not right. So we should be picking up on that and seeing them. So we shouldn't be giving these long periods of uncontrolled opioid medication.
So the second week of prescription, for example, may be a very good reason
be a trigger
to treat the patient. Andrea?
We are actually trying to do opioid-free anesthesia, and I thought a lot about that last night. I actually am not so sure anymore that that's the part that really matters. And whether we aren't going overboard there and get unintended consequences. I would agree with Lee. Anything after surgery should be restricted in a reasonable fashion, but to go completely without opioids might actually, in the long run, intraoperatively, prove wrong.
I agree with that. We tried to go in the UK opioid-lite in the operative period,
makes sense,
and then focus on leaving the patient needing as few as possible going home. The reason is people dive in with alternatives that are relatively under-evaluated. We don't know their full safety profile. They've never used it before, but they're going to use it today on Mrs. Miggins, who's high risk. So I think don't rush at that one. Is that a fair comment?
Absolutely.
Opioid-lite to start with.
So.
Absolutely.
I've seen protocols where they use local anesthetics and they say keep intralipid in the room.
Yeah.
I'm not sure that makes sense.
So proceed with caution.
Top Med Talk. Nick Majerison here. That was an excerpt from an earlier podcast entitled How is Perioperative Medicine Taking Control in 2018 and Beyond? If you search for that on your podcatcher or on topmedtalk.com, you can hear a wide-ranging conversation underneath that headline. How is perioperative medicine taking control in 2018 and beyond?